Anna Abbott. I'm a student physical therapist assistant at Jefferson College of Health Sciences. Today I'm going to be treating a 25-year-old female who suffered a traumatic cervical spine injury 9 days ago in a motor vehicle accident. She was diagnosed with an incomplete C7 spinal cord injury, so she has elbow extension but is unable to flex her fingers. She had an ORIF put in to stabilize and decompress the fracture site utilizing a right iliac bone graft. She is in a Philadelphia collar, and she is unable to sit for longer than 10 minutes due to orthostatic hypotension. She just began an intermittent catheterization program and requires total assist. She also has a stage 1 wound on her right heel, and she also has increased spasticity in her bilateral hip flexors, which I'm assuming is due to her wheelchair use. She lives with her boyfriend and works as a kindergarten teacher. Her and her boyfriend live in a split-level home. She has a 5 out of 5 strength in her biceps and wrist extensors. She also has 4 out of 5 strength in her triceps. She is mod to max assist during bed mobility and transfers. She is dependent in wheelchair use. She is mod to dependent assistance in all ADLs. She can maintain good static sitting balance in short sit and long sit for 1 minute with bilateral upper extremity support. She is alert and oriented ×3 and is able to follow multi-step commands. So the main thing I want to work on today is I just wanted to address her decreased static sitting balance. Main reason I want to address this is because sitting balance is super important in patients who have a spinal cord injury, because being able to sit will enable them to be more functional in their everyday life. It will allow them to put their shoes on, to put their pants on, to put their shirts on, and etc. So to be able to optimally work on sitting balance, the patient needs to first be able to get into the seated position. So for my main intervention, I'm going to have the patient work on transferring from supine to sideline to long sit. And I think the main reason she is unable to do this independently is because she's just not educated on the proper body mechanics on how to get in the seated position, just using her upper extremities for assistance. So once we get in long sit, I'm then going to work on her static sitting balance in long sit, and then when she's in long sit, I'm going to have her sit with both of her upper extremities for assistance in long sit for 1 minute. And if she does well with that, I might take one upper extremity away and just have that in her lap, and she will be decreased to one upper extremity for assistance. And of course, like I said before, seated balance is super important to work on, because the patient needs to learn how to balance in long sit to be more functional in their ADLs. They also need to be educated on how to balance without using their core, since they have no core. And then once we've balanced in long sit for a minute, we're going to rest, and then we're going to move to short sit and balance in short sit for 1 minute. So this will also be good. Balancing in short sit will enable her to begin transferring independently. So it's kind of a pre-transfer training. And of course, pre-transfer training is super important because it enables your patient to get to the stage of transferring independently. And transferring independently is super important because you want your patient to be as independent and as functional as they possibly can be. And that's it.